DS6, this one is, how do we know about the brain? What techniques do we have to study? Your textbook does a lovely cruising through history and then going all the way to the most modern techniques with PET scanning and so on. So initially just, yeah, literally, how do we know from historic approaches, as in what injury, where, dissections post-mortem, and gradually getting through non-invasive and invasive studies all over to the most modern imaging. So going back through ancient Egypt, battlefield surgeons already, and other, literally just evidence is there in some of the hieroglyphics that they have got seizures, epileptic seizures observed, and aphasia, so maybe Broca's aphasia that you've learned about earlier, speech problems after strokes and following brain injuries. So if you've got somebody in a battlefield situation having taken a huge blow to the head and they later developed a speech problem, that was already recognized that there is a link between wax to the head and something is displaying out of the usual. Also, you've got evidence by Galen. Galen is actually a Greek, one of the first medicinal sort of scientists that lived in the Roman Empire, but he linked the idea of having something in the cerebellum being linked to muscle control and senses. So that was the first bit of let's dissect and see what is going on. In the Renaissance, the corpus callosum was identified as part of the brain structure. So literally just very basic drawings, very basic, seeing that there are different structures within the brain once you're dissecting and taking it apart. Following on by very, very detailed drawings of the brain. So detailed drawings that Leonardo da Vinci made to have some sort of idea as to where have you got what. I've taken a bit of a snapshot here of what has been identified from dissections and from drawings there. The idea that there actually are some stringy looking bits connecting to the rest of the body. There was a phase where a study existed. It was the study of phrenology, in the meantime longly discredited, thank goodness, because it was linked to all sorts of sexist and racist arguments. The argument that phrenology had is that different areas of the brain have got different, or kind of lead to different personality traits, and the shape and size of your cranium, of your actual skull, would show what personality a person would have, and if you have a bump here or an indentation here or there, that could cause disorders in personality and so on. So based on head shape, one would predict, oh, that person's going to be intelligent, that person's going to be trustworthy, or simply the link of, if your head is a little bit smaller, you're not as intelligent, which is a fairly racist argument because women do generally have a fairly sexist argument, smaller head circumference, and linking that to intelligence and also racist interpretations. Ridiculous study, but here we go. It was a phase in history that did exist. We then have a lot of evidence from injuries that soldiers obtained in the First World War, and following on from those injuries, the altered behaviour. In the First World War, we already had the development of antibiotics, so injured soldiers could be kept alive following an injury that in the past maybe you wouldn't be able to keep alive, and therefore you could study their behaviour. If one particular area of their brain looked like it's damaged, what behaviour do you get? That gave information about how the brain works. You have got a bit more modern approaches then, and some of that links into what has been done during the years leading up to the Second World War, and having your human volunteers, not human volunteers, to do invasive investigations on. You could link an injury to a clinical assessment. Whether that's a battlefield injury or a stroke injury is irrelevant, or whether you've caused an injury to a particular brain region. You can therefore see what area of the brain will work or no longer work, and what display of behaviours you get from the patient. You could have the stimulation methods in which you could apply an electric current to a specific brain region and then ask the patient to tell you what they're feeling, what what actually experiences happen in their bodies. Now, brain stimulation, deep brain stimulation, is being done as a treatment and is being worked on as a treatment, implanting electrodes. It can help a lot in the treatment of Parkinson's. So there is switching off electrodes in the brain, and then tremors go. So there is actually quite some evidence that you can treat OCD and speech and language problems with the right electric stimulation in the right places. So that is work in progress there. So stimulation methods when active, and obviously that you can have the numbing and anesthetizing methods as well of the brain as a side. Same thing, different angle. And as last one, you can have a number of non-invasive studies. So brain imaging, and there's a lot coming on now in over the next few slides: EEG, CT, MRI, fMRI, and the PET scanning. They're the more modern brain scanning techniques, which each with their benefits and drawbacks. So starting with the EEG, which is non-invasive from the point of view that you're just placing electrodes on the skin, on the scalp. You may have to apply a sticky gel, to get that electric conductivity, to literally just see what electric activity is taking place through the actual bone of the cranium, through the meninges, and see what is happening in the top layers of the brain. You will not be able to get information from further down. It's just literally the top layers. You then, from those electrodes in the brain, can identify spikes. You can identify rhythms. Epilepsy and sleep disorders can be diagnosed like this, and can be done while the person is awake or asleep. And patterns of adults and brains are different. So you might have heard of different sleep patterns, REM sleep. You might have heard of alpha and beta waves when people are awake. The benefits: it's not invasive. Patients do not even have to stay still, so you can apply that to a young child and watch what they do on an electric level while you see their behavior at the same time. You do not have to be, and later techniques mean that you have to lie still in these enclosed spaces in an MRI machine, for example. Some patients just cannot tolerate that. Some patients cannot have the electric or the magnetic interference because they've got metal parts on their body somewhere. Can detect in a very, very short time range. So you can watch behaviors, let's say a fit, and at the same time the electric waves at the same time. But the drawback is you can only see what's happening on the surface of the brain, so the grey matter of the surface. Yeah, that is benefits and drawbacks. Next one, that one already gets you into a machine. Think of this as X-ray slices being taken bit by bit by bit, slice after slice after slice, through the brain area. Now, it is using X-rays, several X-rays in a row. You can already think, oops, that's going to be a health problem. Obviously, you can, with a lot of software involved, create a 3D image of, let's say you found a tumor, you want to know what it's looking on a 3-dimensional level, and you've got those slices. You can just reconstruct from the slices what it would be looking 3-dimensional. Benefit: it is still non-invasive. You can detect tumors and hemorrhages and clots, can all be done in a very short period of time. It's kind of a very useful thing. It's been a little bit overused though recently, those techniques. You can slice the head sort of at different angles, sideways or a little bit diagonal or in top-down slices. The problem is the cancer risk, because you've got a huge number of X-ray exposures, slice after slice after slice. And the temptation of a neurosurgeon, for example, of just going, let's do a CT, that temptation, because we've got that technique, needs to be outweighed by what benefit risk we've got to the patient. So that is now being looked at through a different angle, because if you know the cancer risk, is it really meaningful to take the risk of doing a CT? Right, next technique used, MRI or magnetic resonance imaging. There are two different types. One literally just what have you got, and the other one when it's active. So fMRI, that's going to be looking at active regions of the brain. If you're just looking at what there is in the brain, the way that it works, if you remember water from your core concepts, water is a dipole. It will align itself if you're giving it an electric field. Electricity and magnetism are not that far off each other. The physics students amongst you will know more about that here. In a strong magnetic field, your water particles align. They align themselves according to the magnetic field due to their electric charges. If you then bother them a little bit, give it a little bit of a radio wave pulse, they will start to wiggle and flicker for that little while. That movement can be detected. You get your fancy cameras reacting to that. So it's literally aligning the water molecules and then giving them a little bit of a slap, making them wiggle with radio waves. Can be detected. Again, can be read within milliseconds. If you want the functional MRI, the what regions of the brain are active. But at the moment, this is just to get an image of the brain. The fMRI. The fMRI functions with the additional information of respiration. If you've got an area of the brain that is active, you have a blood oxygen level dependence here. So if there's more oxygen being used up, you can detect oxyhemoglobin and deoxygenated hemoglobin, and they respond slightly differently. The same idea, you have got the magnetic field, everything aligns itself, give it a radio wave whack, and it starts to wriggle for a short period of time, and you can detect that. Again, you can, from the getting information in from all your cameras and which depth you're recording from, you get a three-dimensional image mapped. Loads of software involved in doing this. Can be used in planning all sorts of surgery, but can also be used in psychological studies. If I do this to a person, if a person is thinking, let's say, thinking about food, which areas are active in the brain, or thinking about writing, or then actually writing something rather than thinking about the writing, you can identify the different regions, or thinking about speaking or getting the patient to speak, you can actually map what is going on. Benefit is you have got higher sensitivity than the CT, so it's kind of already outdating CTs, especially the risk is nowhere near as much. However, it's expensive and it does take time. You can get a good contrast between the grey and white matter. You get a good contrast, so identifying tumours is possible. You can detect where is it vascular and where is it brain tissue. So if you have got a vascular problem, a blood supply problem, an aneurysm is when your blood supply is widening out. So if an artery isn't having a strong enough muscular or connective tissue layer and it's just bulging, or vascular dementia, there are various versions of which Alzheimer's and dementia can set in. If it's blood supply related, you can identify that. Big drawback, anyone who's got a hearing implant or any metal pins in their bones to hold them together, or any metallic dental work, then you cannot have somebody in the MRI machine. Anything metallic needs to be taken off. Even the little metal bit on a hairband can cause trouble to an MRI procedure. Now, the reality is you're going into a very, very tight tube. You have to lie absolutely still. It is noisy. Very often patients are being given headphones just for the sake of, just listen to some music and ignore the noise that's there. You can have additional shadows showing up that may not be cancers or may not be harmful to the patient. So surgery might be planned from a little shadow and then nothing is actually there. It can apparently get hot in there. I haven't had one done, but people in my family had MRIs done. So it gives us ideas. Last technique in your syllabus, that is your positron emission tomography. So PET scanning. Again, that one is not being done unless you've got a serious thought of something is wrong because of the cancer risk, because you're actually getting a tracer into the body. During your GCSE days, you should have been, as part of the radioactivity unit in physics, you should have been taught about medical tracers, something that should have a short half-life so that it's out of the body very quickly again. The radioactive isotope of fluoride that's being used for that it literally needs to be prepared and within the next so many hours injected, and then you need to get your PET scan done. So it's a bit of a timing thing, but also the patient is afterwards, the person is radioactive for a short period of time. So keeping them physically away from children and pregnant women is going to be already a dilemma, and keeping staff safe is a huge dilemma, but that's a different story. So what's the actual tracer? You're using glucose, the deoxyglucose. You're using a glucose that has had an oxygen removed and a fluoride put there instead. So it's a replacement. It's a radioactive glucose. Glucose is used in areas of the brain that are active. So more glucose will be traveling to the areas of the brain that are actually active. And as that tracer goes through the brain, it will gradually, randomly decay. Radioactive decay is random. You're going to randomly get decay processes, and you're going to get positrons hitting electron. You get that the gamma waves produced when the positron is hitting an electron. That can then be detected by a scanner. So it's a bit of a therefore, but think of the fluoride hexaglucose as a glucose with a radioactive fluoride instead of an oxygen. Uses of it, diagnosing cancers, obviously. You can see what areas are active wherever the glucose is being used. So speech areas, Alzheimer's diagnosis, wherever in Alzheimer's is an additional thing. The use of glucose is lowered in a patient with Alzheimer's. You can separate that from, let's say, the vascular dementia as a different pathway. Psychiatry, in psychiatry, you can use a tracer that instead of just generally binding to glucose, you can have a radioactive tracer attaching to dopamine or serotonin or generally opioid receptors to figure out what areas are responsible in which conditions you're investigating, whether it's schizophrenia, substance abuse, mood disorders. And you can also have a tracer binding to a tumor if you know that they're binding sites on a particular cancerous tumor, to help later on when you do surgery. If you have got a little detector for that radioactivity, you can then find and trace where actually is your tumor, or is anything radioactive still left, is any part of the tumor still left when you do surgery. Drawback: it's expensive. You have to have, even more than the MRI scan, expensive. And you've got to take your timings. You've got to get your timings right between making the tracer, injecting it, and then the actual scan being done. But also the risk to the patient, the cancer risk to the patient and to people around. So has to be considered in the bigger scheme of things. I believe that was the last one. Okay, next one is going to be the neuroplasticity one.